Hello friends, this is Dr. Rakesh Mittal, your surgery friend. So now in this class we'll do appendix, right? In appendix, anatomy is relevant, surgical aspects, different incisions used for operating appendix, acute appendicitis, the scoring, the typical triad symptoms, right? And the important clinical signs. And in the end we'll cover the tumor part. Okay, this is important in appendix. Small topic, can be done very quickly. It will not take more than 15-20 minutes to revise appendix, right, for any exam you are going for. So starting with the anatomical questions, which of the following statements is false? The appendicular artery arises from right colic artery, right? This is wrong. It arises from ileocolic artery, or can also be called ileocecal artery. I'll just show you the picture. Yeah. This is regarding the positions of appendix. All of you know, you've been reading this right from the MBBS. So I'll quickly go through it. Retrocecal is the most common position, 75%. Then second most common is pelvic, towards the pelvis, right? And then you have the pre-ileal, post-ileal, the other positions. Now this is the vascular supply, right? So this is the ileocolic artery. Okay, ileocolic is a branch of superior mesenteric artery. Superior mesenteric artery supplies most of the small bowel, starting from the duodenum till the right colon, mid colon. Okay, the junction of the foregut and the midgut. Okay, so that's the ileocolic artery. So ileocolic artery goes down, so it gives a branch to supply the cecum. So that's why we call it ileocecum, cecal artery also. And the inferior division of this gives rise to this is the appendicular artery, the branches of appendicular artery. Okay, so this is easy. Now, commonest position of appendix is retrocecal. I've just shown you. Position of base of the appendix is constant. Again, in this diagram, you can see 1, 2, 3, 4, 5, 6 positions of appendix, but all of them have the same base. The base is constant. It's a direction of the appendix. It's a tail. The direction of the tail decides a position, right? But the base is constant, irrespective of the position. Submucosa is rich in lymphoid aggregates. That is true. It is rich in lymphoid tissue, and this is a lymphoid tissue only is a starting event in the acute appendicitis. Now, argentophin cells found in the base of crypts, yes, this is true. We'll see there is a very prominent tumor in appendix, that is carcinoid tumor, that starts with the argenta. The origin is these argentophin cells. We also call it argentophinoma. I have a question in the end. We'll discuss it there in details, right? So that's the first question. The second one is 30-year-old male presented to surgical emergency, acute pain, right lower abdomen, one day, diagnosed acute appendicitis, planned for surgery. During surgery, surgeon was unable to locate. This is very common. I myself, I've been operating appendix for more than probably 22, 23 years now. Right, it has happened once in 3-4 years, 5 years it happens. You are not able to find appendix, right? Then you have to look for the clues for where you can find appendix, right? You have to use your experience. What structure should surgeon follow to reach the possible? First is you mobilize cecum and then identify tinea coli, the single most important. So don't get trapped with the option of all of the above. Whenever we get a question with a choice all of the above, 90% students tend to tick that all of the above should be the answer, but it's not the case always, all the time. Okay, tinea coli, the 3 tinea coli, I'll show you the picture. Yeah, that's a picture. See, that's the number 1, 2, and that's a third one. The 3 tinea coli running on the colon. Entire colon has tinea coli, appendices epiploic. I'll just show you that picture also. Identification of colon anatomically, surgically is done by these two things. And third, hostrations. You can see these are hostrations. Hostrations. Okay. So number one, hostration. Second is tinea coli. Third is the appendices epiploic, which are nothing fat-filled vesicles. I think, yeah, that's a picture. Epiploic appendages, appendices epiploic. You can see these small dots all across the colon. These are small fat-filled pouches. Okay, this is not found in small bowel or anywhere else. Only in the large bowel colon. So the three tinea coli, where these three tinea coli they meet, that's the base of the appendix. That's the best and single most important. 99.99% you will never miss this. You will not fail. Okay, so you just mobilize cecum and see the these tinea coli and follow these, and where you see the point of union of three tinea coli, that should be the normal position of the appendix. So it's tinea coli. Terminal ileum cannot help you because it's separate. Okay, separate from the appendix. Appendices epiploic used for the identification of colon. It will not help in identification of appendix. Okay. Easy. Now, third question, a 15-year-old diagnosed with acute appendicitis, surgeon could not, similar question but different choices. What steps should the surgeon undertake to locate the appendix? Again, same answer would be the same. Mobilize cecum, trace tinea coli to the confluence. So that's the answer. Okay, ureter is separate. In appendix surgery, we never see the ureter. It's behind. It's a retroperitoneal structure. So never try to locate ureter. Okay, inspect the mesentery root. No. Coccus maneuver. This is for duodenum. It's not related to mobilization of the duodenum. Right. I'll just show you the picture. I think I have a picture. Yeah, that's it. Normally, duodenum was like this. Okay. See, this is the duodenum. We have lifted this. Okay, we have lifted this. So duodenum has been mobilized towards the left, so that and this yellow structure, this is pancreas. This is pancreas. This is duodenum. Duodenum along with pancreas is mobilized on the left, so that you can see the structures behind, mainly the vessels. Two big vessels, IVC and aorta. You can see this is IVC, this is aorta. Okay, so if you have to operate on IVC, or you need to remove the lymph nodes behind, or some structures behind are needed, so you need to mobilize duodenum. Even the pancreatic surgeries, many duodenal surgeries, you need to mobilize duodenum. So this is called Coccus maneuver. You should know this. That can be another separate question. Okay, so we are done with this. Now let us move on to the proper appendicitis. 23-year-old male came to surgical emergency, 7 days history of pain, right lower abdomen, occasional vomiting, no fever, not toxic. On examination, there is a lump in right iliac fossa, lump, mildly tender, no generalized peritonitis, a diagnosis of, so the whole story is not required now. We have the diagnosis, appendicular lump. What is the best treatment for this patient? Now let me, before going on to this, let me tell you the natural history of acute appendicitis. A patient comes to you with acute appendicitis. The ideal treatment is surgery, appendicectomy. Within 24 to 48 hours. As soon as the patient presents, as quick as the patient presents, you should remove the appendix, unless it is very mild. Nowadays, the new data, new literature is coming up that very mild acute appendicitis can be managed conservatively with antibiotics. But broadly, for the exam purpose, acute appendicitis, the treatment of choice is appendicectomy, right? But patient may not present in initial 1 or 2 days. Patient is bearing pain, having painkillers at home with someone's advice or on his own. So patient lands up on 4th day, 5th day. Okay, so patient waited. So that golden period of 1 to